Bismillahirrahmanirrahim. This work aims to upgrade your knowledge with latest published guidelines and guidance introduced to you by Marwa Elfayoumy. Starting with malnutrition, frailty, and sarcopenia in patients with cirrhosis, 2021 practice guidance by the American Association for the Study of Liver Disease. This work dedicated to the soul of my father. Starting with the difference between guidance and guidelines. Guidelines, it is a systematic review of the literature, formal rating of the quality of the evidence, and the strength of the recommendations. If appropriate, it analysis of results using the grading of recommendations, assessment, development, and evaluation system. While guidance is developed by consensus of an expert panel and provides a guidance statement based on formal review and analysis of the literature on the topic. The ASLD Practice Guidelines Committee chose to perform a guidance on this topic because of sufficient number of randomized controlled trials weren't available to support the development of a guideline. Starting with some definitions. Multiple definitions of these conditions exist in the published domain outside of the field of hematology, but consistent definitions haven't been established by the ASLD for patients with cirrhosis. Starting with malnutrition. Its theoretical definition is a clinical syndrome that results from deficiencies or excess of nutrient intake, imbalance of essential nutrients, or impaired nutrient utilization. And operational definition applied to the patient with cirrhosis is an imbalance, deficiency, or excess of nutrients that causes measurable adverse effect on tissue and body forms as body shape, size, composition, and function, and the clinical outcome. Frailty. Its theoretical definition is a clinical state of decreased physiological reserve and increased vulnerability to health stressor. While the operational definition that applies to the patient with cirrhosis, the phenotypic representation of impaired muscle contractility function. Sarcopenia. Sarcopenia is a progressive and generalized skeletal muscle disorder associated with an increased likelihood of adverse outcomes, including falls, fracture, disability, and mortality. While its operational definition applied to the patient with cirrhosis is a phenotypic representation of loss of muscle mass. Sarcopenic obesity refers to the states of decreased muscle mass in the setting of increased fat mass. This phenotype presents a unique clinical challenge in that it can be difficult to detect because fat mass can mask underlying muscle wasting. Rates of sarcopenic obesity are likely to increase as cirrhosis related to non-alcoholic fatty liver disease increase. These three constructs are interrelated and in practice are often recognized simultaneously in an individual patient. For example, a patient with cirrhosis who presents to clinic with severe muscle wasting might be described as malnourished, frail, and sarcopenic, each descriptor conveying similar information about the patient's poor clinical condition and prognosis. Despite this, in clinical practice, there is value in understanding each as a separate entity, as well as the relationship between the three in order to develop tailored behavioral interventions and targeted pharmacotherapies for these conditions. Relationships and contributing factor. Malnutrition as inadequate intake or inadequate uptake, excess intake of micronutrients, and defect in digestion and absorption. This leads to manifestations of muscle dysfunction as frailty and sarcopenia. Starting with etiological factors, which may be cirrhosis-related, adverse system-related, as systemic inflammation and metabolic dysregulation, physical inactivity, and environmental factors. Those lead to clinical phenotypes as frailty and sarcopenia, and those lead to adverse health outcomes in the form of increasing decompensation, increased healthcare utilization, decreased health-related quality of life, death, and adverse post-transplant outcomes. So, the impact of frailty is frailty has been strongly linked with mortality-independent liver disease severity in various clinical settings, including the ambulatory setting, acute care setting, the post-transplant setting. This was shown in a study including 734 hospitalized patients with cirrhosis. Disability as assessed by the need for someone assistance with activities of daily living more than 3 was associated with a nearly twofold increase of adjusted of 90-day mortality. This is shown as a Kaplan-Meier curve present on the right side of the screen. Change in Frality is associated with mortality. Among 1,093 patients with cirrhosis at the 8 US sites, each 0.1 unit change in the liver Frality index over 3 months was associated with a twofold increased hazard of waitlist mortality, independent of baseline Frality and MELD sodium score. Cumulative rates of waitlist mortality at 6 months were 12.1% among those who experienced severe worsening, compared with 7% among those who remained stable. This highlights the importance of interventions targeting Frality to reduce mortality in this population. Frality also associated with outcomes other than mortality, as in ambulatory patients, unplanned hospitalizations, healthcare costs, recovery of physical function after liver transplantation, and in hospitalized patients, readmission, prolonged length of stay, discharge to a rehabilitation facility as non-home setting. Frailty is strongly associated with patient-reported outcomes, including development of falls, depression, disability, and global health-related quality of life. Sarcopenia has been shown to be a robust predictor of a wide spectrum of outcomes in adults with cirrhosis, both with or without hepatocellular carcinoma, as mortality both before and after liver transplantation, hepatic decompensation, reduced quality of life, increased risk for infection, and prolonged hospitalization. Disease prevention and management. There are 3 levels of disease prevention and management. Starting with primary prevention, which aims to prevent development and delay the onset, and secondary prevention, it is early diagnosis and prompt initiation of treatment and slow progression, and tertiary prevention through rehabilitation and reverse. The assessment is happening through the diagnostic toolbox, which is at primary prevention, malnutrition assessment, and assessment of muscle dysfunction. And for the secondary prevention, evaluate for etiological risk factors, explore dietary preference and barriers to exercise. And for the tertiary prevention, reassess for prognosis of malnutrition, frailty, or sarcopenia by primary and secondary preventive effort. All those levels prevent the occurrence of undesirable health outcomes. So the management toolbox for the primary prevention through education, patient and caregiver, and encourage positive health behaviors and empower patient with specific skills. And for secondary prevention, apply management toolbox, co-management with a registered dietitian and certified exercise physiologist and physical therapist if available. And for tertiary prevention, we are doing the same with considered center-based rehabilitation, intensive nutritional supplementation. So the guidance statements for the 3 levels of disease prevention and management. Primary prevention. All patients with cirrhosis should receive education, motivation, and behavioral skill support to reduce the risk of development of these conditions. In secondary prevention, a positive frailty or sarcopenia screen should promote evaluation for underlying etiological risk factors and the development of an ambulatory personalized management plan. And for tertiary prevention, patients with progressive frailty or sarcopenia despite initiation of secondary prevention efforts should undergo more intensive nutrition and exercise rehabilitation under the direct supervision of a registered dietitian and certified exercise physiologist and physical therapist. Systemic assessment in clinical setting. In clinical setting, systemic assessment of frailty and sarcopenia in all patients with cirrhosis using a standardized instrument. So, frailty testing may be particularly useful in ambulatory setting and when intermediate term and long-term longitudinal assessment are needed to assess natural progression or response to treatment. While sarcopenia testing may be particularly useful for patient on home administration of tests of frailty are not feasible or impractical, as in patients in acute severe illness or inability to participate in the testing as in very young children. While the guidance statement in assessing in research studies of patients with cirrhosis, including clinical trials, evaluating intervention related to malnutrition or muscle dysfunction recommendation to assess of both frailty and sarcopenia, when possible, to more comprehensively capture the impact of interventions in these complementary endpoints. Now to the guidance statements to the tools to assess frailty or individual frailty components that have been studied in patients with cirrhosis. Starting with subjective tools as starting with clinical Frailty scale. The clinical Frailty scale is taking for the administration time less than 1 minute. It's used for global Frailty, and it is a rapid survey based on instrument using clinician assessment on a scale from 1 to 9, and it is 1 very fit, 5 mildly frail, and 9 is terminally ill. The other is the activity of daily living. It's used as ambulatory inpatient, taking about from 2 to 3 minutes, and it is for patient or caregiver assesses difficulty or dependence with sex activities that are essential to function within one's homes, as passing, dressing, transferring, continence and incontinence care, meal preparation, and feeding. And that is for the KPS, which is taking less than 1 minute, and it is carrying the patient to caregivers or clinician assessment and functional limitation ranging from 100, which is the normal, not compliant, and no evidence of the disease, to 50, which is the patient in it requires considerable assistance and frequent medical care, and 210, which is the patient is fatal process was progressively rapidly and it is at end stage. Using other subjective tools as Runners Key Performance Scale, Eastern Cooperative Oncology. For the objective tools, there are Frailty instrument, which consists of 5 domains: weight loss as a questions, exhaustion as questions, and slowness as short gait speed, weakness examined by hand grip strength, and low physical activity level, which is a questionnaire. The hand grip is measured by hand dynamometer. Modified Frailty instrument, which is developed for the children, and the hand grip strength alone by the hand dynamometer and the cardiopulmonary exercise. The cardiopulmonary exercise, it is using as a non-invasive test of functional capacity through measurements of gas exchange at rest and during exercise to evaluate both submaximal and peak exercise response, and thus evaluating the cardiopulmonary stress diagnostic system. This is the hand dynamometer. Other objective tools as short gait speed as one of the components of the short physical performance battery, and 6-minute walking test, short physical performance battery, and liver Frailty index. The liver Frailty index is taking about 3 minutes, and its assessment of the physical Frailty, and it is Cirrhosis specific tool consists of grip strength, chair stand, and balance testing. It changes the liver Frailty index are associated with. This is a 6-minute walking test that showing the distance walked on flat surface at usual walking speed within. This shows the short physical performance battery, which is consists of the balance test, which the ability to stand side by side stand for 10 seconds, and semi-tandem stand, as we can see here, and tandem stand, and the gait speed test and also chair stand test. Sarcopenia tools. Sarcopenia tools, we are using the anthropometric measurements and mid-arm muscle circumference with triceps skin folds and thickness, which is used in the adults and children, and it's more specifically in children comparison between the mid-arm muscle circumference and CT. It's practical for large patient population, but poor accuracy and precision interpreted with caution. The bioelectrical impedance is safe, rapid, and accessible with minimal moderate training, and it can be repeatable, but fluid retention may impact the reliability of lean body mass estimation. But data using phase angle show good reliability even in patients with fluid retention. Ultrasound. Ultrasound is safe, rapid, accessible, and repeatable, but it is operator dependent and challenging in patients with obesity and lack of normative data. So more data are needed to standardize technique, able to provide echogenicity data for tissue integrity. MRI, it is accurate, non-radiation, and measurable muscle quantity and quality, but costly, limited its availability. Muscle mass has been defined by fat-free muscle area. Using DEXA scan is also used, but low concordance between the DEXA and the CT in the patient with cirrhosis. CT scan has the most evidence to support its use, but has a challenging with radiation exposure and repeatability. Muscle mass measurements that have been studied as total psoas area, psoas muscle index, and total skeletal muscle attenuation. So the guidance statement for Frality and Sarcopenia Tools. Frality: there are insufficient data to recommend the use of one Frality tool over another. Instead, recommendations of selection of the standardized Frality tool in clinical practice should depend upon the relative need for efficacy versus objectivity of assessment within the clinical scenario. In patients with decompensated cirrhosis, annual Frality assessment may be sufficient, whereas patients with decompensated cirrhosis may benefit from more frequent every 3 to 6 months assessment. Sarcopenia: there are currently insufficient data to support a bedside tool to assess muscle mass in patients with cirrhosis. Assessment by CT image analysis is recommended as the most constant and reproducible method to quantify muscle mass in patients with cirrhosis. Because the risk of exposure to radiation, use of abdominal CT solely for the purpose of muscle mass measurement is not recommended for routine use. MRI measurements for skeletal muscle mass hasn't been validated in the patient with cirrhosis, but theoretically provides the same information on muscle mass as CT imaging. So all patients with cirrhosis, if both are screening for malnutrition and frailty or sarcopenia are normal, we have to educate the patient and reassessment the patient again. If abnormal, we have to identify the contributing factor and the management strategies or the management toolbox, and finally reassess the patient again. Management strategies. The actions that will be taken for specific management strategies recognized around etiology. Starting with the action to cirrhosis related. Site is causing early satiety, limited exercise capacity, and immobility. It's treated with TIPS and liver transplantation. Some patients who have undergone TIPS placement display increased lean body mass and decreased visceral fat. Frailty and sarcopenia are associated with adverse outcomes post-liver transplantation. Frailty improves 1 year post-liver transplantation most, but only 40% meet criteria for robust at 1 year after liver transplantation. 30% of liver transplant recipients display improvement in muscle mass, but 25% develop new onset sarcopenia post-liver transplantation. So the guidance statement: TIPS placement and liver transplantation for standard indications may offer an indirect benefit of improving muscle mass. There are insufficient evidence to recommend using Frality or sarcopenia as absolute indication or contraindication against liver transplantation. Action taking to other system-related as systemic inflammation and obesity. In general, systemic inflammation is associated with frailty and sarcopenia. Systemic inflammation markers increase in obesity, chronic HSV infection, and alcohol-associated liver disease. So the guidance statements: treatment of liver disease associated with inflammation is recommended. Weight loss from 5 to 10% may reduce disease progression and portal hypertension. But intentional weight loss decreases lean mass and bone density, but this can be prevented by resistance training. So the guidance statement: if weight loss is medically required, reduce overall caloric targets while maintaining protein targets based on ideal body weight. Cautions is advised at weight loss and decompensated liver cirrhosis. Resistance training should be recommended to decrease muscle loss. Action 2: energy expenditure and timing of food intake. Patients with cirrhosis have increased total energy expenditure, and this leading to a catabolic state with relatively short fasts. So the guidance statement: fasting time should be minimized with a maximum interval of 3 to 4 hours while awake. To minimize nocturnal fasting time, an early breakfast and late evening snacks should be recommended. Calories needs should be personalized in patients with screen positive for frailty and sarcopenia. Indirect calorimetry is the gold standard for measurement of actual resting energy expenditure, but it is not widely available in all practice settings, and high inter-individual variations in measuring versus predicted value of resting energy expenditure in the patient with cirrhosis. So, if indirect calorimetry is unavailable, to calculate resting energy expenditure, use of predictive or weight-based equations. Only 30% of patients prescribed low sodium type were adherent. Those who were adherent had 20% decrease of caloric intake. So, in patients who screen positive for frailty or sarcopenia and can't meet nutritional targets on sodium-restricted diet, liberalization of sodium restriction should be considered to facilitate adequate oral intake. Protein intake. The guidance statement recommended daily protein intake for adults with cirrhosis about 1.2 to 1.5 gram per kg ideal body weight per day, and for critically ill, a target of 1.2 2 gram per kg ideal body weight per day is recommended. And a diverse range of protein sources, including vegetables and dairy products, should be encouraged. And branched-chain amino acid supplementation is not recommended by emphasizing the importance of meeting daily overall protein target from a diverse range of protein sources. And the most important, protein intake shouldn't be restricted in patients with hepatic encephalopathy. Nutritional intake in the hospitalized setting. All hospitalized patients with cirrhosis should receive formal consultation with a registered dietitian within 24 hours of admission, then assessment for malnutrition using the Royal Free Hospital Nutrition Prioritizing Tool. Strategies to minimize fasting periods or frequency of nothing per oral orders should be implemented. Consider advancing diet rapidly when there is no indication for NPO states. And oral nutritional supplementation is the first-line therapy for hospitalized patients with cirrhosis who are unable to meet energy needs via biological intake alone. Intra-nutritional supplementation should be considered to achieve targets in patients unable to meet energy needs with a biological intake and oral nutritional supplementation. But precautions should be taken to reduce risk of aspiration and development of hyperglycemia. The presence of esophageal varices is not an absolute contraindication to placement of an enteric feeding tube, but close monitoring is warranted for signs of rebleeding if enteric tube is required after recent banding of esophageal varices. Parenteral nutritional should be reserved for patients with cirrhosis who are intolerant to enteral nutrition, unable to meet dietary intake required via oral intake alone. Micronutrient deficiency should be assessed at least annually and repeated if deficient and reassessed after repletion. Physical activity-related action. Engage in frequent physical activity. Physical activity-based interventions are recommended to improve muscle contractility, function, and muscle mass in patients with cirrhosis. This includes assessing and reassessing Frality and/or Sarcopenia using standardized tools, recommending a combination of aerobic or resistance exercise, and tailoring recommendations based on assessments. Intervention targeting user system, hormone-associated interventions. In one study of 101 male patients with cirrhosis and low testosterone level, testosterone replacement increased muscle mass, decreased fat mass, and improved glucose metabolism. The anabolic effect of testosterone on muscle may be related to suppression of muscle cell apoptosis and myostatin production. However, exogenous testosterone is also associated with increased risk of hepatocellular carcinoma and thrombophilia. So the guidance statement, testosterone therapy may be indicated for some men with cirrhosis, but the risk-benefit profile must be individualized. For men with personalized family history of hepatocellular carcinoma, prostate cancer, thrombophilia, the risk of testosterone replacement may outweigh potential. And finally, to sum up, this is a diagnostic toolbox with screen for malnutrition and assessment for Frality and Sarcopenia by clinical conditions, physical examination finding, and objective measurements. And we have to identify the risk factors, the contributing factors for the malnutrition and Frality and Sarcopenia, and management toolbox for liver-specific with physical activity, intake and uptake, and other systems. And finally, takeaway message. Malnutrition is imbalance of nutrients leads to clinical phenotypes. As Frality, loss of muscle contractility function, sarcopenia, loss of muscle mass. Frailty and sarcopenia are prevalent in both adults and children and strongly associated with adverse outcomes. The three levels of disease prevention and health promotion framework can be used to tailor resources based on the individual patient's risk for and severity of Frailty and sarcopenia. Primary and secondary prevention, diagnostic and management toolboxes, and secondary and tertiary prevention. Don't forget for the co-management with a registered dietitian, certified exercise physiologist, and health behavior specialist. And thank you.